Good evening. Thank you guys for joining us for the AACFAS Virtual Journal Club for the month of April. First and foremost, I want to thank PICA, our sponsors, who allow us to do this wonderful journal club every month. This evening, we have the great pleasure of having Dr. Adrian Ross as a PICA representative. Dr. Adrian Ross is a graduate of the New York College of Podiatric Medicine and attended the Western Pennsylvania Hospital for Surgical Residency. She then completed a one-year fellowship in trauma and reconstructive surgery at Jewish University of Louisville Medical Center. She's originally from Ohio by way of Great Britain. Currently, she practices in Atlanta, Georgia, and serves as faculty for Emory DeKalb Podiatric Surgical Residency. She's immediate past president of the Georgia Podiatric Medical Association and serves as chair of Department of Podiatry and Department of Orthopedics at Emory Decatur Hospital. Dr. Ross publishes lectures and enjoys a surgical emphasis on lower extremity skin and muscle flaps for complex wound closure, as well as peripheral nerve reconstructive techniques. Thank you, Dr. Ross, for being here. It's an honor to have you. I know you're out of the country joining us, so we really do appreciate it.
Thank you for having me.
So to get into the journal club, we have the great privilege of having, the Michigan Minimally Invasive Reconstructive Foot and Ankle Surgery Fellowship here, both Dr. Loder and Dr. Peralta, who are going to present on some great topics that are near and true to their hearts. I just kind of wanted to make a point to say, the whole purpose of these virtual journal club lectures was to try to show or provide a framework that when it comes to reviewing these articles or evidence-based medicine, there is a more scientific or kind of standard way that we can look at it. And it's important for all of us in the profession. And I know Dr. Ross will chime in a lot. Even if you quote unquote don't like research, it's really important for you to be able to read and assess an article and determine its validity, because that's what's going to be our standard of care. That's the standards that we're going to be held against you. And no one wants to be sued, but it's really important when you're, looking at a profession and looking at these articles that you really need to understand how valid they are, because it is something that we're going to be held, as a standard to. So again, purpose of this is not to get into the nitty-gritty of the numbers. The purpose of this journal club was really just to present a framework to residents and students and other attendings. This is how you can assess the validity of a journal article. That way it can help you in your practice. So I'll stop talking and I'll introduce Dr. Diego Peralta. He's a fellow for Dr. Loder's fellowship. Again, the fellowship is Michigan Minimally Invasive and Reconstructive Foot and Ankle Surgery. Thank you both for joining us.
Thank you so much. Hello, everyone. This is Dr. Peralta, completing my fellowship this year under the directorship of Dr. Brian Loder, and thank you for having me. And so we'll get started. So this is the first article I'll be presenting on. This is a level 2 prospective control study comparing minimally invasive distal chevron osteotomy versus open distal chevron osteotomies for hallux valgus correction. What makes this paper interesting is that instead of focusing on mid to long-term correction, for which previous articles have shown similar outcomes between techniques, it specifically looks at the ultra short-term post-op period, meaning the first 2 to 12 weeks. So this is really about early recovery, how patients feel, how they function, and how they mobilize right after surgery. So why does this study matter? MIS techniques have become increasingly popular, largely based on the idea that less soft tissue disruption should lead to faster recovery. The issue is that most of the literature focuses on mid and long-term outcomes, where MIS and open techniques tend to look very similar. So this study is addressing a more practical question, whether MIS actually improves the early post-op experience, which is what patients often care about the most. And so again, the article design, this was a prospective control study, 63 total feet, 33 in the MIS group, and 30 in the open group.
Jessica, I'm sorry, can I interrupt? His slides are not current. Is it, Diego, are your slides not presenting?
My slides on my end are current. I don't know if there's a lag. I just got your text message about it.
No, they're not. It's not coming through. Can you put it in presenter view?
Yeah.
Maybe.
It is in presenter view.
No, not on us.
Oh.
There you go.
Okay. Sorry about that. I don't know what happened.
So go to presenter view.
Let me figure this out. Give me a second. Hmm.
Is your screen shared?
No, I'm gonna go ahead and share it
Yeah,
again.
share it again.
So what was happening with the slides? We're on
Well,
there.
it was just showing the first slide only.
Oh, okay. I think there's gonna be a lag on the presenter view because I had it on presenter view already. So maybe I can just increase the zoom on this current slides so there's no lag. Let me try it. If that's okay, maybe we can do it like that. Let's see. Um, okay, maybe we'll do it like this. Okay, let me share back my screen. Okay, share. Share. Can you guys see my screen now?
Yes.
Okay. Do you see me flipping back and forth?
Yes.
Okay, so I think maybe we keep it like this so it doesn't lag on presenter
Perfect.
view. Okay, so where were we? We were on this study design. I apologize about that. So again, prospective control study, 63 total feet, 33 in the MIS group, 30 in the open group. They performed a power calculation based on minimum clinically important difference of 19 points for AACFAS scores and achieved an 80% power, which strengthens the validity of their findings. However, two important limitations here are that the study was not randomized and all the procedures were performed by a single surgeon. So while surgical consistency is high, this does limit generalization. So baseline characteristics were largely comparable between the groups. Age, intermetatarsal angle, hallux valgus angle were all very similar, suggesting that deformity severity was well matched. The one notable difference was that distal metatarsal articular angle, which was higher in the MIS group, that could potentially, in theory, influence the correction mechanics. So it's something important to keep in mind when we're interpreting these results. So the outcomes that were measured, the primary outcome was AACFAS scores. They also included a wide range of secondary outcomes, including functional scores, patient-reported outcomes, objective range of motion measurements, and swelling. One of the most clinically useful outcomes they included was analgesic consumption, which gives a real-world sense of what post-op pain looks like beyond just the scores. And so these were the results. So what did the results show? At 2 and 4 weeks, minimally invasive patients had about a 10-point improvement in AACFAS scores compared to open, which was statistically significant. By 6 weeks, the scores remained higher in the MIS group. By 12 weeks, the difference disappeared entirely, suggesting that this benefit is limited to the early post-op period. What about the Japanese Society for Surgery of Foot score? So the score shows a more sustained benefit with MIS compared to AACFAS. Not only are there early improvements at 2 and 4 weeks, but the difference persists out at 6 and even 12 weeks. This highlights how different outcome measures may capture recovery different and suggests that functional improvement may extend beyond just what AACFAS scores detect. So what about pain and medications? Pain scores were significantly lower in the MIS group at 2 and 4 weeks, but what really stands out is the medication usage. MIS patients used about 5.5 NSAR per foot compared to nearly 27 in the open group. So the way that the article described NSARs, where your typical non-steroidal anti-inflammatory drugs and metamizole, which is a non-opioid analgesic antipyretic that's used in many parts of Europe and Latin America, but it's banned in the United States and United Kingdom. So as you can see, this was almost a fivefold difference, which suggests a very meaningful difference in the early post-op pain from a practical standpoint. Now, range of motion. This is a big one. Range of motion is one of the strongest findings in this study. At 2 weeks, MIS patients had nearly double the range of motion compared to open. What's most important is the difference persisted through 12 weeks, suggesting a sustained functional advantage that could impact rehab and patient satisfaction. What about swelling? This is another big one. Swelling was measured objectively using foot circumference, which is a nice strength of the study. MIS patients have significantly less swelling at all post-op time points beyond 4 weeks. This supports the idea that less soft tissue disruption leads to improved early recovery and likely contributes to improved range of motion and pain. What about radiographic outcomes? Radiographic correction was comparable between both groups with no differences in HVA or IMA. There was a statistically significant difference in offset favoring MIS. By offset, meaning the dorsal displacement of the metatarsal head, but the magnitude was only about 1 millimeter. So while statistically significant, this is unlikely to be clinically meaningful. And the reason this was a measure and reported in this study is because there's this concern that MIS chevron osteotomies and fixation could leave the metatarsal head dorsally elevated, which could contribute to transfer metatarsalgia. What about complications and surgical details? So there were no major complications reported, which is reassuring. However, the MIS group had a significantly more aching osteotomies. This is important because it could influence outcomes, particularly the alignment and the possibly pain, making it a potential confounder in the study. So overall, MIS provides a clear early recovery benefit: less pain, less swelling, improved range of motion, and reduced medication use. However, by around 12 weeks, these differences largely disappear, and both techniques achieve similar clinical and radiographic outcomes. So the main advantage of MIS appears to be improving the early post-op experience rather than long-term results. Okay, so part of the task I was given was not only to summarize the article, but also critically appraise it. So right now we're going to, as I said, critically appraise this article to see if the results are valid, clinically meaningful, and actually applicable to our practice. So we're going to start with the fundamental question: what exactly is this study trying to answer? So we're looking at hallux valgus patients undergoing surgery, comparing MIS versus open chevron, and specifically focusing on early post-op outcomes. What I like about this is that this is a very clinically relevant question. It not only answers does it work, but does it actually help patients recover better early on in their post-op course, which is something, like I said before, patients really care about. Next, randomization. So were patients randomized? The answer here is no, patients were not randomized, and instead were assigned based on surgeon workflow. This is important because it introduces selection bias, meaning there could be underlying differences between the groups that were not fully accounted for. So right off the bat, this weakens the internal validity compared to a randomized controlled trial. Next, baseline similarity. Despite the lack of randomization, the groups were actually pretty comparable at baseline. The demographics and deformity severity were very similar, which is reassuring. There was one difference, as I mentioned before, and that was the DMMA. But overall, the groups were reasonably well matched, so that helps reduce but not eliminate the selection bias. Next, equal treatment. So for the most part, the groups were treated equally. They had the same surgeon, identical post-op protocols, which is a big strength. However, there was a key difference. The MIS group had a significantly more aching osteotomies. That's important because, as I said before, that could influence outcomes like pain or correction. So that's a potential confounder. Next, follow-up analysis. This is actually a strength of the study. There was minimal loss to follow-up. The patients were accounted for in the analysis. So from a data completeness standpoint, this study holds up well. Next, blinding. There was no blinding in this study. Both the surgeon and the patients knew which procedure was performed. This becomes especially important because many outcomes like pain, satisfaction, and even function are and can be subjective. So this introduces potential bias in how outcomes are reported. Treatment effect. The biggest difference that we're seeing were early on, especially in pain, swelling, and range of motion. The medication use difference was particularly striking with much lower use in the MIS group. However, by around 12 weeks, these differences were largely disappear. So this is really an early recovery benefit, not a long-term difference. Next, precision. In terms of precision, the study shows statistically significant results. However, the sample size is relatively small and confidence intervals aren't clearly reported in the study. So while the findings are promising, the precision is somewhat limited. Next, applicability. Can we apply this to our patients? I think yes, but with some caution. This reflects a fairly typical bunion population, so it's applicable clinically. But since it's a single surgeon study with short follow-up, we have to be careful about generalizing too broadly. So overall, are the results valid and meaningful? I would say yes, with limitations. This is a well-designed prospective study with clinically relevant findings, but the lack of randomization and blinding, along with the small sample size, limit how strong the conclusions can be. That said, it does provide a good evidence that MIS improves early recovery. And that is it for the first article. If anybody wants to chime in or add anything.
I mean, this was absolutely amazing. I think this is the third or fourth journal club that I've moderated, and this is probably the best kind of critical appraisal summarized. This was a great job. I don't really have much to add in regards to, you went through each of the questions through the Oxford of critical appraisal sheets, addressed them and kind of explained. So you did it perfectly. And I think this is a great example to the audience where you read this article and you read it and you're like, oh, great. It shows that MIS is way better and you're, shaking hands and making fist pumps. And then when you start to kind of break it down, still a very good article like this last slide that you showed, but you start to kind of see the weaknesses when you really start to use these guidelines. So I thought you did a great job. I think kind of two things that I just wanted, not with your analysis, but just with this that I wanted to point it out is I did find it, I don't know if the word is interesting or maybe it was a positive that they use 6 different AFOS, FVAS, SF12, like different, things to analyze it at the end. And, they said AOFAS and that Japanese one were the ones that, showed that beneficial outcomes. And I kind of want to point out, and I use AOFAS all the time in my research, but really it hasn't been shown to be a good reproducible validated scoring system. The Japanese one, absolutely. VAS, SF36, those are really good scoring systems. AOFS, we use a lot in our profession, but it's really not as valid as the other one. So I did kind of want to point that one out, but you did a great job. Dr. Ross, do you have anything to add?
So I was actually going to make the same comment about AOFAS scoring system because this has come up quite a bit. And a lot of times I think when students and residents are seeing it, they're not understanding kind of the difference between the different scoring systems. And from a medical legal perspective, it matters. And then when it comes to our documentation, oftentimes, like I saw the VAS, pain scale was in there. That's really important to actually include that in our documentation, especially pre and post-operatively, so that we can have a measurable, objective, much more measurable scale as to how the patient is progressing from pre-operative to post-operative to ultimately, hopefully, healed. So I think that those points are very important. I liked seeing the range of motion that was accounted for in there. The analgesic use, considering in the age of narcotic use and abuse, is really, really important. So I think from a documentation perspective, any type of standardization, if the attendings can hear that, is really important to carry through on all of your patients. So I really did enjoy that presentation. Thank you.
Thank you. Thank you for the feedback regarding the AOFAS. I don't think it's well known as far as not being very reproducible among studies. So I appreciate the comment.
This would be a question for either yourself or Dr. Loder. I am curious, as a center that does a lot of MIS, when you read this article, it said, well, the reason why we looked at short-term outcomes is because there's already been studies out there about long-term outcomes. But, going to clinical relevance, I kind of wanted to get your guys' viewpoint. What do you think the clinical relevance is of having better early outcomes? Because you even mentioned in your presentation that, long-term outcomes, this isn't looking at. So do you think besides maybe the analgesics being less, what is the clinical relevance of having better scores early on?
I probably can answer that. Just for what we see, patient satisfaction is in the early onset. We still haven't got to the long-term American outcomes of 5 to 10 years, which we're just about to hit, where we can report recurrence rates and which is most important. But what the patient satisfaction based on in the studies we do with patient-reported outcomes at our practice, patients are far more satisfied by the three things that this study highlight, and that is decrease in pain, decrease in swelling, and a better range of motion, which is what they're looking at to get back to functionality earlier. And that's how they really predict the success of this procedure is how soon can I get back to what I was wanted to get at initially. That's where the excitement is in this procedure.
Yeah, I would concur in my short experience with doing MIS with Dr. Loder. One of the things that when we bring the patients in for their 8-week appointment is they're ready to, hey, how much can I do? Hey, can I start running? Can I start lifting weights? And we kind of have to start setting those boundaries because they're not quite ready yet, but they feel so good that that's almost unanimously the question that comes up at that 8-week appointment.
So I don't know if this is a good analogy, so correct me if I'm wrong. So it's kind of like what we do with Achilles tendon ruptures, right? Long-term outcomes are essentially the same, but quicker return to activity, we operate on them. Would that be a good enough analogy of what you guys are saying?
Exactly. Yeah. The studies all show, besides recurrence rate, the studies all show that at 12 months, the swelling's down, the range of motion is better, the patients can fit in the shoes, they're happy with their surgery. The only thing that we're going to find the difference is the recurrence rate different. That's the big thing, right? But the most important part is how soon they get to those things and who gets to the finish line quicker, and that's what the patient remembers. I was able to get in shoes faster. I was able to get back to my activity faster. So exactly the same thing. That's why all the 1 year studies are about the same. And we really want to see the 5 and 10 year studies give us better data on recurrence rates.
Dr. Ross, one more question for you. I'm sorry.
Yeah.
I've seen you lecture multiple times, and every time you talk about scoring system, I'm like, I got to put a dot phrase in my note, and I never do. So if I had to put in a scoring system that was simplistic enough that I can keep my clinic going, which one do you think, you mentioned VAS, which one do you think would be the most beneficial?
VAS is a really easy one. And I have patients do it and sign their sheets before we even do surgery. For one, because it doesn't seem like it's just me actually taking note of that. They're actually the ones dating it and signing that that's what their pain scale is. And then post-operatively being able to do that. I think that that's probably the most powerful one, just because to the lay person as well, they've at least heard some idea about it. They have even told me about it. So I think that that's something that's a good, easy kind of communicator to patients. So that's a great question. The other question I was going to pose as well was, to both Dr. Loder and Dr. Peralta was, when I look at this research, the first thing I think about is this may be good criteria to eventually be able to say, hey, this is a better candidate. Maybe it's a patient who in the past has had, a history of narcotic abuse, but they're doing better with that. And, being able to use studies like this to be able to justify as well, even a further strength of tending more towards MIS, that would be interesting. Or maybe someone who's more prone to maybe arthritis or AVN. So I think that that has significant clinical implications.
We definitely tend to see a better population in the athletic who want to keep first MPJ range of motion and stay more functional. That's definitely true. I want to talk about the VAS pain score because we've adapted that. We actually have a sign right in the on by their examination chair. And so every time preoperatively, I make them look at the sign and I make them point to which one it is. We use AI, so it's automatically transcribed the response. It can never get wrong. And so I
Mm,
always ask what their VAS score is, and I say, look at the chart and tell me what you see. And they point to the number, and then post-operatively for every visit, we track that VAS score. And so that's part of our transcript on every patient, so we can go back and pull that data.
that's great. That's great. That I can't tell you how many times that has come up in med mal cases, where they're assessing how a patient is doing based on that VAS score. That's probably the one that I see the most. So,
All right, well, if we don't have any more questions, you want to move on to the second article?
Yes, let's do it. All right. All right. So now I will be presenting on the second article. This is a level 1 randomized control trial comparing minimally invasive versus open correction of lesser toe deformities. So what makes this paper particularly strong is the randomized design, which we did not have in the first study. Also, while the first article focused on early recovery, this one focuses on long-term outcomes at 18 months with a primary emphasis on safety and complication rates, which arguably are even more important when deciding surgical approach, especially with a certain patient population. So why does this matter? Lesser toe deformities are extremely common in our practice, and we have multiple surgical options. Open techniques have been traditionally the standard approach, but MIS is gaining popularity. The issue is that high quality comparative data, especially randomized trials, is very limited. So this study is really trying to answer, do we get the same outcomes with MIS? And more importantly, can we reduce complications? So this was a prospective randomized control trial with 100 patients evenly divided between MIS and open surgery. They used block randomization with seal envelopes for allocation concealment. Follow-up was 18 months, which is long enough to assess not just for clinical outcomes, but also for bone healing, recurrence, and complications. However, it is a single center study, which may limit some generalization. So patient flow and follow-up. The study screened 118 patients, 100 were randomized. At final follow-up, 95 patients were available, and complete data sets were obtained for 84 patients, giving an 84% full data capture rate. Only 5 patients were lost to follow-up. Baseline characteristics were largely comparable between groups. Age and gender distribution were similar, and while there were slightly more diabetic patients in the MIS group, this was not statistically significant. One notable difference was higher prevalence of clawed toe deformities in the open group, and this could potentially influence outcomes, which could potentially, which would be something that should be kept in mind when interpreting these results. So interventions. This is actually a very important slide, and one that impacts how we interpret the study. The MIS group underwent percutaneous osteotomies and soft tissue releases. The open group, however, underwent PIP joint arthrodesis, which is fundamentally a different procedure biomechanically. So while the study is comparing MIS versus open, it's not just comparing approach, it's comparing different surgical procedures. Joint preserving versus joint sacrificing. That becomes very important when we talk about outcomes like stiffness, bone healing, and complications. Importantly, both groups had identical post-op protocols, including partial weight bearing for 4 weeks and K-wire removal at 4 weeks. So outcome measures, the primary outcome in the study was safety, specifically complication rates. Secondary outcomes included functional outcomes using the foot function index score, patient satisfaction, and radiographic and clinical correction. So compared to the first article, this study is much more focused on long-term durability and safety rather than early recovery. So satisfaction, patient satisfaction was very high in both groups, with about 88 to 90% of patients satisfied. There was no statistically significant difference between MIS and open surgery. Functional outcomes. Both groups show significant improvements in function. The FFII score improved substantially in both groups, with slightly graded improvement in the MIS group, but this difference was not statistically significant. Similarly, the mean number of painful days measured as painful days over the past week decreased significantly in both groups. Again, no difference between with no difference between the techniques. So functionally, both approaches perform equally well in the long term. Clinical outcomes. Clinical correction rates were excellent in both groups, with about 95% achieving good or satisfactory alignment. Recurrence rates were very low and identical between groups. Persistent shoe conflict was also rare and similar between groups, suggesting both techniques are equally effective at achieving durable deformity correction. Bone healing. This is one of the most important findings in the study. The MIS group had a 100% union rate, whereas the open group had about an 82% union rate, with 6 cases of non-union, and the other 2 having a partial osseous consolidation. This was statistically significant and clinically meaningful. The authors suggest that this may be due to better preservation of the blood supply in MIS and bone biology, as the osteotomy in MIS often maintains one intact cortex, whereas in the open arthrodesis involves complete joint preparation. Complications. Complications were significantly higher in the open group, particularly related to soft tissue healing and infection. There were also differences in hardware complications, that is, a K-wire, migration in MIS versus deformation in open procedures, but overall rates were similar. Overall, MIS demonstrated a better safety profile, particularly in reducing soft tissue-related complications. So overall, both techniques provide excellent clinical and functional outcomes. However, MIS offers a clear advantage in terms of safety, particularly with fewer wound complications and improved bone healing. So once again, we're going to go through the appraisal of this research paper to examine if the results are valid, clinically meaningful, and applicable to our practice. So we're going to start with the fundamental question: what exactly is the study trying to answer? We're looking at patients with lesser toe deformities, comparing minimally invasive techniques to open correction with outcomes focused primarily on safety and secondarily on function and satisfaction. What I liked about this question is that it's highly clinically relevant. It's not just asking whether MIS works, but whether it provides an advantage in terms of complications, which is often what drives decision-making in these cases. Randomization. This is one of the biggest strengths of the study. Patients were randomized using block randomization with seal envelopes, which is an appropriate and commonly used method to ensure allocation concealment. This significantly reduces selection bias compared to the first paper we discussed. Because of this, we can be more confident that the differences in outcomes are due to the intervention rather than baseline differences between the groups. Baseline similarity. So baseline characteristics of the groups were largely well-balanced. Age, gender distribution, and comorbidities like diabetes and neuropathy were similar between groups, which is reassuring. There was a statistically significant difference in deformity type, with more claw toes in the open group, as I mentioned before. Now, this could potentially influence outcomes, particularly stiffness or recurrence, so it's a minor imbalance, but overall, the groups are still reasonably comparable. Next, equal treatment. This is probably the most important limitation in the entire study. The groups are not treated equally. The MIS group underwent joint-preserving osteotomies, while the open group underwent PIP joint arthrodesis. So this is not a pure comparison of MIS versus open. It's also comparing 2 different surgical procedures, and this becomes especially relevant when interpreting outcomes like non-union rates. So we have to be cautious about attributing differences purely to surgical approach, meaning MIS versus open. Follow-up and analysis. The follow-up in this study is actually quite strong. About 95% of patients were available at final follow-up, with complete data sets for around 84% of the patients. Loss to follow-up was low, around 5%, which is acceptable for a surgical study with an 18-month follow-up. This reduces the risk of attrition bias and increases confidence in the results. What about the blinding? Blinding in the study was partial. Clinical assessments were not blinded because of the surgical scarring of the procedure, which introduces some degree of performance and detection bias, especially for subjective outcomes like satisfaction and functional scoring. However, radiographic assessments were performed by blinded evaluators, which strengthens the objectivity of the outcomes like bone healing and alignment. However, I'm not exactly sure how the blinded radiographic evaluation was performed when procedures that were performed were significantly different, and maybe even at an 18-month follow-up, you should be able to see the difference between an osteotomy and an arthrodesis procedure. So overall, there is some bias present, but partially mitigated. Treatment effect. Here's the treatment effect here was very interesting because it's not just about improved function. Both groups achieve similar functional outcomes and satisfaction levels, which suggests that both techniques are effective. The real difference lies in the safety. MIS have fewer wound complications and a significantly lower non-union rate. So the benefit of MIS in this study is primarily in reducing complications rather than just improving functional results. What about precision? In terms of precision, the study has a relatively adequate sample size for a surgical randomized controlled trial with 100 patients total. They were able to detect statistically significant differences in key outcomes like non-union and infection rates. While confidence intervals are not heavily emphasized, also in the study, the consistency of findings and the magnitude of differences suggests that these results are reasonably precise. Applicability. So when we talk about applicability, we can take these results and apply them to our own patients. The answer is yes, but definitely with caution. On one hand, this study includes a very real-world population with common lesser toe deformities, and the post-op protocol is standard and reproducible. So in that sense, it's very applicable to everyday practice. However, the key limitation, and this is important, is that, as mentioned before, this is not a pure comparison of MIS versus open approach. So when we try to apply these results, we're not just deciding between MIS and open, we're also deciding between preserving the joint versus fusing it. That means some of the observed differences, particularly in bone healing and complications, may be influenced by the type of procedure itself, not just the surgical approach. So I would say this study is applicable, but only if we interpret it within that context and avoid overgeneralizing the results. So overall, this is a high-quality level 1 study with strong methodology and clinically meaningful findings. The randomized design and good follow-up significantly strengthens its validity. However, the biggest limitation is that it is not a pure comparison of MIS versus open techniques. Because of that, we have to be cautious in interpreting the results, especially when attributing differences in complications, as I said before, like non-union. That said, the study still provides strong evidence that MIS techniques can achieve equivalent outcomes with a potentially improved safety profile. And that's all I got.
Once again, a great job. I even loved how you compared this one to the first one and the pros and weaknesses. And again, kind of just briefly, superficially looking at this article, you're like, oh, this must be a great one. It's a prospective, randomized, blinded. This has to be great. But then when you start really analyzing it, you can see this huge weakness. I mean, this is where I think it kind of gets hard. You know, I love critical appraisals and that we kind of make it black and white and go stepwise approach. But is this weakness a big enough weakness that it kind of mitigates all the positives about it? And that's what's hard. It's not like we're assigning a number value to each one of these in order to score it. And that's, I think, what was hard for me with this article, is because everything else was great, but really not comparing the same procedure to the same procedure. And is that a big enough issue that it really changes the validity as opposed to the first one?
Yeah, absolutely. That's a very fair question. And I don't know what the determining line would be for that.
Do you guys do mostly arthrodesis for your hammer toes? Or are you doing arthroplasty, or again, is it just patient dependent?
It's actually more deformity dependent for us, and so we classify them in the flexible, semi-reducible, and non-reducible or rigid deformity. And so we'll do the P1, P2 osteotomy that they presented here in a semi-reducible deformity where the osteotomies will give us a rectus toe, but in a rigid, non-reducible deformity, we'll do an MIS arthrodesis. So we have the capability of comparing the MIS of two. Our recent study we just put out was based on the extra-articular osteotomies only, which had pretty good patient-reported outcomes. But we are going to be looking at the data of the arthrodesis and the osteotomies and compare those two. Unfortunately, when you're a really deeply involved MIS surgeon, it's hard to go back to the open procedures. So comparing open to MIS, I can never really talk myself into doing that to a patient. So that's where our troubles are on comparing those two. And I brought up to Diego about the first study. We didn't bring this up, but in that first bunion study, we never learned how experienced those surgeons were. We
Yeah.
don't know if those were the first 30 or the first. We have no idea if they were really good volume surgeons. Because what we learn in MIS is really high volume surgeons don't go back to open. So it's hard for us to compare the two. It really is.
Yeah.
I'm glad you brought that up because I was going to bring up in regards to this too, because there are some industry promoted studies that are out there that for some of these MIS like Lapidus procedures, they've shown like this is how many cases you have to do before you can be considered, well versed at this. So again, going back to like a liability, if you get complications with an MIS surgeon and this is only your sixth MIS surgery, can that be held against you? I think that's another discussion too, is, at what point are you considered competent? Should we even be looking at that? Because are we kind of hindering us as a profession? Because then everyone's afraid to get sued for their first 50, right? So I think that's another interesting thing. I'm glad you brought that up, because, for me, who's not as well, versed as you guys are, I always say with my MS bunions, it's a love-hate relationship. I hate it during the case because I'm just not as quick as I am with an open, but I love it after, sort of thing. But now to look at on the other aspect, if I get a complication and this is my 10 MIS, like could that be held against me? I don't know.
And I think that's a good question for Dr. Ross, but I will tell you that one of the things that AOFAS did a year and a half ago or a year ago was stopped accepting articles based on learning curve because they defined an era in where individuals could get a negativity scar against them because of the learning curve. So we have stopped talking about it or accepting journal publications on the learning curve with MIS because it was dangerous in the legal world. Do you agree with that, Dr. Ross?
I 100% agree. That's something that's come up in other disciplines or other surgical endeavors as well. And I think that that learning curve, for instance, like even at my hospital at Emory, those are things that we look at, whether it's ankle fractures or it's, an ankle arthroplasty. So MIS, the same, that's also been looked at is have we gotten out of that learning curve phase? Because you're right, when it does come to court, that is something that's looked at. It's not just whether or not you're, board qualified or board certified, is how many of these cases have you actually done? And if you have one complication and you've done 100 cases, versus you've only done maybe 15 cases, that does come up. And it's a question that always is asked. And it's a little bit more difficult to stand on it if you've not really endeavored upon it in your training, particularly as well, because all of that is considered in if you're doing a fellowship, obviously, that is a good place to, if you're going to do some learning, that's the place to do your learning. So it's a catch-22 is because obviously when we come out, there are always newer modalities and newer procedures that are coming out. And obviously you've got to learn somewhere, but at the same time, as far as being able to publish on that, I think that can skew kind of the understanding of what we're looking at.
I agree completely.
Yep.
Yeah. I almost want to change that term, like we've come up with, forget learning curve and want to switch it to comfort curve. When are you fully comfortable with the procedure? So it's a little softer on you, you know?
I like that. I
Yeah.
like that, especially in the climate right now.
Exactly.
Well, you did a great job of going through each of the critical appraisal questions. And I even like the color scheme, like you put yellow for kinda, green for good, red. I mean, it was good. You did a great job. So with that being said, you have about 10 minutes left if you want to kind of talk about your fellowship, a little bit about it, type of fellow that you're looking for, Dr. Loder. The floor is your guys.
Perfect. I appreciate that. Thanks. First of all, I think Diego did a fantastic job. He deserves kudos for putting this together. Normally, I'm fairly hard to do a presentation in front of, and when he did it to me this afternoon, I had nothing to say besides one little thing. So I think he did a fantastic job, and he knows that I'm quite critical. So, we have a benefit of this Michigan Minimally Invasive Fellowship is it's something unique. Because it's mostly what we do, which is not a lot of programs. I mean, everything I do is based on MIS, or at least we focus. So, I mean, we do have one of the only focused MIS fellowships. It is 12 months. We take one fellow. It's in Southeast Michigan, where there are a lot of residency programs. So, podiatry in general is highly acceptable. It's probably harder to be an orthopedic foot and ankle surgeon in our community than it is to be a podiatrist because it's been there so long, which is great. We operate on the full spectrum of forefoot, midfoot, rear foot, and ankle. Uh, Trust me, when I can finally figure out how to do a total ankle MIS, I will, and I'll let you guys know because I look for everything on MIS. We only have two faculty members, so the mentorship is extremely strong. We have a very large clinic, lots of patients flow through, and we have a high volume of MIS as well as a strong clinical experience. So that the fellow spends a lot of time seeing patients in the clinic, which is extremely important. I think too many fellowships are bouncing around doing surgery without learning how to, and you'll appreciate this, Dr. Ross, without learning how to talk to a patient appropriately, how not to say the wrong words, how to make them feel comfortable, how to back yourself out of complications, how to make the patient feel the center of the universe, which makes them very important because that's what it's about. So I feel like our fellowship not only teaches you MIS, but it's a strong mentorship on how to approach the patient and how to keep them satisfied. And if you can do that, you're going to have a stellar practice. I truly believe so. And I think to go to the next slide, Diego, I think that the actual philosophy says it all. And that we look at every procedure and every patient through a minimally invasive lens. And that's what we do. How can we turn this procedure into the smallest amount of footprint so we disrupt the smallest amount of tissue, we have the least amount of disruption, less swelling, and less pain? And as Diego knows, the littlest amount of suturing feasibly possible to get out of a case, because I hate suturing. So that's the whole goal. And it's funny that Diego didn't mind suturing, and by the end of this year, he doesn't like it just as much as I do. So we both enjoy the same thing, getting it out with the least amount of suturing. We are now accepting fellows in our 2027-28 cycle. We'll be accepting applications for another 15, 30 days, and then we're going to pick our fellow going forward. I feel we have a fantastic education. I'm going to let Diego say a few minutes about what his experience has been, and then we will call it a night.
Thank you, Dr. Loder. That's all true. That is all great. I would say one of the things that I underestimated before coming to this fellowship, as you mentioned before, was the clinical approach, the strong clinical versatility. You're seeing truly what a podiatric surgeon would see on a busy practice, um, ranging from musculoskeletal, electives, trauma, wound care. We treat it all. And I've gotten so comfortable in this year working up those patients, boarding them for surgeries, participating in the surgeries, and participating in the post-ops. So essentially, you're on your way of becoming what a first-year attending would be like. And so I would encourage anyone that's looking for something like that, to shoot me a text, send your application over to Dr. Loder. at the email there. You can always text me as well. It's been a fantastic year thus far. And another advice that I would give for anyone that's listening that would like to do a fellowship in the future or is in the process of applying is, find something that you really want to do in your fellowship year. Make it count. For me, now that I've gone through the application process of jobs, everything that I've learned here in this fellowship is significantly applicable to every job opportunity out there. Again, we're podiatrists. We do foot and ankle surgery, but we also see those patients in clinic. So, like I said, you get the full range, and you get something different, a different perspective on how to treat patients. Again, through minimally invasive approaches. And yes, there is a comfort curve. 100% agreed. And the ability to learn it correctly, and the ability to learn it from someone that has been doing it for a long time, it's really invaluable. It really almost neglects and erases that comfort curve when you're out in first year practice. So I'm super thankful for everyone in AACFAS for um, the uh, the moving forward of the fellowships, and for Dr. Loder and everyone here listening today. This has been an amazing night.
Well, thank you guys very much for being here, Dr. Ross, Dr. Peralta, Dr. Loder. I'm walking away with the comfort curve. That's my take-home message for tonight. So I appreciate all of you guys being here. This was great. I really do appreciate it.
Thank you for having us, Jessica, and Dr. Ross. It was great to meet you on the virtual.
Likewise. Thank you.
Have a good night, everyone.
You too. Thank you.
All right.
Thank you
Good
so
night.
much, doctors. Have a good night.
You as
Good
well.
night.
Good night.